So today we will discuss the lumbar plexus and its branches. So lumbar plexus is formed by the ventral rami of lumbar nerves and its branches, and the plexus is lying within the substance of the psoas major muscle, and its branches are coming out from different borders of the psoas major muscle and then supplying mainly the lower limb or perineal regions. Okay. So we will discuss individual branches. You prepare lumbar plexus as a short note, okay, or individual branches of it like femoral nerve, obturator nerve. These are important nerves of this plexus, and this plexus, these important nerves also comes as a short note. Okay. Next. Okay, so lumbosacral plexus. So the anterior anterior divisions of the lumbar nerves, sacral nerves and coccygeal nerve form the lumbosacral plexus. Okay, so this part is lumbar plexus, this is sacral plexus, and this part is the pudendal plexus or coccygeal plexus. So the first lumbar nerve being frequently joined by a branch from the 12th thoracic, and for descriptive purposes this plexus is divided into these three parts: lumbar plexus, sacral plexus and pudendal plexus. Okay, mainly all these are forming together the lumbosacral plexus. It is mainly a continuous plexus, but for descriptive purposes we are dividing it into these parts. Next. See here, ventral rami. What is ventral rami? It has been shown. So this is a section of the spinal cord from posterior aspect. This is dorsal root, and from the anterior aspect, this is anterior root or ventral root. Okay. So from the posterior root entering the sensory fibers, and from the anterior root coming out the motor fibers. And in the posterior root there is a ganglion that is known as dorsal root ganglion, and these two roots are joining with each other to form the spinal nerve, which is coming out through the vertebral foramen, and then it is dividing into two rami, anterior rami and posterior rami. Okay, and this anterior rami is taking part in formation of this plexuses. Okay, so understood. So the spinal nerves L1 to L4 form the basis of the lumbar plexus. At each vertebral level, paired spinal nerves leave the spinal cord via the intervertebral foramina of the vertebral column. And each nerve then divides into anterior and posterior nerve fibers, anterior and posterior rami. And the lumbar plexus begins as the anterior fibers of the spinal nerves L1, L2, L3 and L4. They are together forming the lumbar plexus. Next. See, these are the four roots: L1, L2, L3 and L4. These are the four roots of the lumbar plexus. And these are the branches you can see. From L1, there are two branches: Iliohypogastric nerve and Ilioinguinal nerve. Ilioinguinal nerve you have seen in the dissection of inguinal canal. Also Iliohypogastric nerve you may have seen. And this is Genitofemoral nerve that you will see in the posterior abdominal wall. Next, this is lateral femoral cutaneous nerve. This is lying in front of the anterior superior iliac spine and becoming cutaneous after passing through the abdominal muscles. Then two large nerves are present: femoral nerve and obturator nerve. Root values are same: L2, L3, L4. This is from the ventral division obturator nerve, and this is dorsal division. That is the difference. So obturator nerve is coming out from medial border of the psoas major. That's how you identify this nerve, and it is lying in front of the ala of the sacrum, part of the oil structure. Okay, and supplying the adductor muscles of the thigh. You have seen in the inferior extremity. And femoral nerve is coming out. It is a thick nerve coming out from the lateral border of the psoas major muscle, and it is entering into lying posterior to the inguinal ligament, lying lateral to the femoral sheath, dividing into two divisions, anterior posterior divisions, supplying the quadriceps muscles and different joints. Okay. Next. So, course of each nerve and their supplying area and some clinical aspect will be described. Okay, so individual nerves we will start describing. So, first the iliohypogastric nerve. See, this green one is the iliohypogastric nerve. It is getting its root value is mainly L1, but sometimes if the T12 is joining, then it may be T12 and L1. Okay. So as it is lying first along the psoas upper border of the psoas major, then lying in front of quadratus lumborum, in front of the iliac crest, then passing between the transversus abdominis and internal oblique, supplying these muscles and being divides into these two branches, anterior cutaneous branch and lateral cutaneous branch. So this is the course and supply of this muscle. Next, see here. So this is quadratus lumborum, this is psoas major, and here is with the flat muscles of the abdomen. Okay, transversus abdominis, internal oblique, external oblique. So this nerve is coming out from the lateral margin of psoas major because lumbar plexus is lying within the psoas major. Iliohypogastric nerve. This upper one is iliohypogastric. Crossing across this quadratus lumborum, then lying between these two muscles, transversus abdominis, internal oblique, and then piercing through these muscles, becoming cutaneous, anterior and lateral cutaneous. Okay. Next. So this is the innervation, sensory innervation to the internal oblique, external oblique, transversus abdominis muscle, suprapubic skin and posterolateral gluteal skin. This is supplied by iliohypogastric nerve. And motor innervation is given to transversus abdominis, internal oblique and the conjoint tendon. What is the clinical sensation, clinical significance? If the nerve is injured, there will be burning pain in the suprapubic and inguinal region. It is giving sensory supply here, so there will be burning pain in the suprapubic and inguinal region. So injection of local anesthetic and physical therapy is given in treatment of this. And this nerve get injured mainly due to pelvic injuries during different sports and surgical injuries, and rarely in pregnancy due to the compression. There is rarely a case of isolated iliohypogastric nerve injury. Actually, these two are injured together. Ilioinguinal nerve is also involved. Okay, because root values are same for those both of them. Both root value is the L1. Okay. Next we go to ilioinguinal nerve. So this is ilioinguinal nerve. This green colored one. Root value is L1. So it passes over the quadratus lumborum, then iliacus, then transversus abdominis, internal oblique, passes in between these two, okay, and then enter the inguinal canal, piercing through its roof, lying within the inguinal canal, coming out through the superficial inguinal ring, and lying along with spermatic cord in males and along with round ligament of uterus in females. Okay, understood? And supplies the perineal area. Next, see here is the iliohypogastric becoming cutaneous, and here is the ilioinguinal nerve lying over the quadratus lumborum, then iliacus, then between the transversus abdominis and internal oblique, and then entering into this inguinal canal, coming out through the superficial inguinal ring and supplying the perineal area mainly. Okay. Next, so what is the sensory innervation? Skin of the superomedial aspect of thigh and groin region. In males, anterior 1/3 of the scrotum and root of penis. In females, anterior 1/3 of the labia majora and root of clitoris. Motor innervation is given to the transversus abdominis and internal oblique. What is the clinical significance? Nerve can get damaged through surgery or injury to the abdominal wall. weakened transversus abdominis and internal oblique will be there because these muscles were getting supplied from this ilioinguinal, also getting supplied from iliohypogastric. Inguinal hernia leads to stretching of this nerve and leading to compression effect over this nerve. Nerve entrapment, here you gave the physical therapy and manual therapy. Inguinodynia, there is chronic pain in the groin region. If this nerve is involved, there will be chronic pain in the groin region. Next. Next we go to genitofemoral nerve. Root value is L1 and L2. See, this green colored one is the genitofemoral nerve. It is lying over the psoas major muscle, anterior surface of psoas major. Then it divides into genital branch and femoral branch. And they are passing downward medially in the deep inguinal ring. This genital branch is entering into the deep inguinal ring. Okay. And femoral branch is entering into the femoral sheath, okay, lying in the lateral compartment of the femoral sheath. So genital branch is passing through the inguinal canal. It is a part of the spermatic cord, okay, and in males it is supplying the cremasteric muscle, scrotal skin, anterior, and this femoral nerve passing through the femoral canal and innervating this. In case of the genital branch was supplying cremasteric muscle, scrotal skin in male, and innervating the mons pubis and labia majora in females. Okay, and also in the round ligament of uterus in females, and the femoral branch passing through the femoral canal, supplying the anterior layer of the femoral sheath and fossa lata, and supplying skin of the upper anterior part of the thigh. So this is the supply of these two branches. Okay. Next, here is the genitofemoral nerve. So it is lying anterior to the psoas major muscle, dividing into two branches, genital branch and femoral branch. Genital branch is becoming part of spermatic cord and supplying the cremasteric muscles and scrotal skin in case of male, and mons pubis labia majora in females. And this femoral branch is passing through the femoral sheath and supplying the upper medial aspect of the skin of the thigh. Okay. Next. So what is the innervation? Motor and sensory innervation. Femoral branch is exclusively sensory in nature, while genital branch is both sensory and motor in nature. What is the significance? Genitofemoral neuralgia. There will be lower abdomen and pelvic pain, and it may aggravated by the kinetic exercises. Okay. Next we go to lateral cutaneous nerve of the thigh. Root value is L2 and L3. So this green colored one is lateral cutaneous nerve of the thigh. Medial and intermediate cutaneous nerve of the thigh, these are branched from femoral nerve. You have seen anterior division of femoral nerve. Whereas this lateral cutaneous nerve of thigh is direct branch from the lumbar plexus. Okay. So root value is L2, L3. It is lying along the lateral border of psoas major, then passing through obliquely over the iliacus muscle, going to the anterior superior iliac spine, then piercing the muscle here, and this opening is known as lacuna musculorum, and it is going to the sartorius muscle, divides into two branches, anterior posterior branch. Anterior branch is supplying the knee joint, posterior branch is piercing the fossa lata and supplying the lateral and posterior surface of the thigh. Okay. So this is the supplying area of the lateral cutaneous nerve of the thigh, force and supply. Next, see here, this one is lateral femoral cutaneous nerve. Root value is L2, L3. After that, lying along the lateral border of psoas major, passing obliquely over this iliacus muscle. Here it is piercing the muscle of the abdomen and then it is passing downward in the thigh and becoming, dividing into branches and becoming cutaneous. Okay. Next, clinical significance, here is the Meralgia paresthetica. There will be numbness, tingling, sometimes pain in the outer thigh compression. Okay, this is given as a clinical aspect. What is Meralgia paresthetica? As a part of the long question or in your MCQs, which nerve is involved? Okay, lateral femoral cutaneous nerve is involved in Meralgia paresthetica. Okay, so there will be numbness, tingling, sometimes pain in the outer thigh and due to compression. And these are the treatment. You exercises may help, heat application or trigger point therapy. Okay, next. Next we go to obturator nerve, one large branch from the lumbar plexus. Okay, L2, L3, L4, and this is coming out from the medial border of the psoas major. Then it is crossing the pelvic ring, going downward and forward on the lateral wall of the pelvis, upper part of the obturator foramen, it passing through the obturator canal. Obturator canal is present at the upper margin of the obturator foramen, and then it is dividing into anterior branch and posterior branch. Obturator nerve we have seen in dissection of the thigh in the adductor compartment. Next, see here, this is the obturator nerve coming from L2, L3, L4, then it is coming out through the medial border of psoas major, passing in front of ala of the sacrum, oil structure from lateral to medial, so obturator is lateral most. Then passing through the pelvis, passing through the upper margin of obturator foramen through the obturator canal, dividing into anterior, posterior branches, supplying the adductor muscles. Okay. Next. So this is clinical significance of obturator nerve. Injury of the obturator nerve, it may be injured in anterior dislocation of the hip joint because it is closely related as it is lying in front of ala of the sacrum in the lateral part, or during radical retropubic prostatectomy. The following are the characteristic clinical features. There will be motor loss, loss of adduction of the thigh due to paralysis of adductor muscles of the thigh. Sensory loss on the medial aspect of thigh due to involvement of the cutaneous branch of anterior division of obturator nerve. Obturator nerve neuropathy. This syndrome of an obturator nerve entrapment causing the medial thigh pain is described in athletes with large adductor muscles. Okay, and this nerve is compressed in between the muscles because of hypertrophy of the adductor muscles in athletes. Surgical division of obturator nerve, it is sometimes done to relieve spasm of adductor muscles in spastic paralysis. Okay, to relieve the pain. Next is irritation of obturator nerve. Inflammation of the ovary causes localized peritonitis in the region of ovarian fossa, and which may cause irritation of the obturator nerve. Obturator nerve is closely related to the ovarian fossa. Okay, and in such case, pain may be referred to the hip, knee, and medial side of the thigh. Referred pain in diseases of hip joint, the pain may be referred to the medial side of the thigh because it is also supplied by the obturator nerve. Next. Next we go to the femoral nerve. So here also root value is L2, L3, L4. These root values are very important. Lumbar plexus very frequently asked in your Viva also. Okay. You may be, and for OSPI all these nerves are important. All these nerves you will see in your posterior abdominal wall dissection. And these thick nerves are very frequently given, femoral and obturator, very frequently given in your OSPI question, and related question they may be asked from the lumbar plexus. Okay. So L2, L3, L4 is root value of femoral nerve. It comes out from the lateral border of psoas major muscle, passes downward between the iliacus and psoas major, lies behind the inguinal ligament, end 2.5 cm below the inguinal ligament and divides into two divisions, anterior and posterior division. Next, see here, this is the femoral nerve, okay. L2, L3, L4 is the root value, then passing between the iliacus and psoas major, then passing underneath the inguinal ligament, entering the thigh lateral to the femoral sheath and dividing into anterior and posterior divisions. Anterior division has one muscular supply sartorius, two cutaneous, intermediate and medial cutaneous nerve of thigh, and posterior division quadriceps muscles, four muscles included in this group, extensor of the knee and hip, and there is, and also supply the iliacus muscle, iliacus part of psoas major, and it is cutaneous nerves is the saphenous nerve, okay, supplying the medial aspect of the leg. So if the femoral nerve is involved, there will be motor and sensory loss accordingly. Next, so what is the clinical significance? Femoral nerve neuropathy. Main trunk of femoral nerve is not subject to any entrapment neuropathy, but it may be compressed by retroperitoneal tumors. A localized neuropathy of the femoral nerve may occur in diabetes mellitus, and the following are the characteristic clinical features. There will be wasting or weakness of the thigh, extending down along the medial aspect of the leg and foot. Here is the sensory supply of the saphenous nerve, okay. An injury of the femoral nerve, it is rare but may be injured by stab injury, gunshot wounds or a pelvic fracture. And the following are the clinical features. There will be motor loss, weak flexion of the thigh due to paralysis of iliacus and sartorius, inability to extend the knee due to paralysis of quadriceps femoris, okay. So the supplying area of femoral nerve is very important. And sensory loss over the anterior and medial aspect of the thigh due to involvement of the intermediate and medial cutaneous nerve of the thigh, and sensory loss on the medial side of the leg and foot up to the ball of great toe, that is up to the first metatarsophalangeal joint due to involvement of the saphenous nerve, okay. So this will be the motor and sensory loss due to injury of femoral nerve. Next. Okay, that's all. Any queries?